Yeah, okay.
So they wanted me to say, do a Q&A, right?
Yeah. Let me know. When are we live? We're live? All right. All right, everyone, let's go ahead and get started. Thank you so much for joining us for the grand rounds. Before we begin, I'm going to do an introduction for Dr. Samir Ahmed here, standing right next to me. So Dr. Samir Ahmed is the chairman of the Department of Endovascular and Image-Guided Surgery at Insight Hospital. His areas of expertise include peripheral arterial disease, superficial and deep venous disease, limb salvage, embolization, and interventional oncology. Dr. Samir Ahmed received his medical degree from Johns Hopkins University. He completed his internship at Yale University, followed by his full residency at Johns Hopkins Hospital. He then went on to complete vascular interventional radiology fellowship at our very own Northwestern Memorial Hospital here in Chicago. Dr. Samir Ahmed is nationally recognized leader. He's published extensively on image-guided and vascular procedures. He's trained many people, from medical students to residents to physician assistants, nurse practitioners, and physicians on the latest in minimal intravascular procedures. He's received numerous awards in his specialty from Radiology Society of North America, Society of Interventional Radiology, Radiology Leadership Institute, American College of Radiology, International Symposium on Endovascular Therapy, and several other institutions for his clinical work and research work. He's also participated in many national clinical trials on treatments of peripheral vascular disease. On a personal side, Dr. Ahmed grew up in New Jersey, moved to Chicago after completing his fellowship here. He currently speaks Urdu, Hindi, and English, and in his spare time, I believe he likes fitness, training, traveling, and spending time with his wife and 2 kids. Please join me in welcoming Dr. Samir Ahmed.
Thank you, Asim. So it's an honor to be here, a pleasure. I wanted to pick a topic that was both cutting edge, and it highlights some of the great things that we do here at Insight Hospital. Can everyone hear me? I just wanted to make sure I'm close enough. So today's focus is on genicular artery embolization, which is a minimally invasive procedure to treat knee osteoarthritis. And it's just one example of the exciting developments in the field of musculoskeletal embolization. While my role as a vascular specialist in treating knee osteoarthritis is relatively small, it's the collaborative effort at Insight Hospital that really makes the difference. So Dr. Bukatz and Dr. Wahood, who are our orthopedic surgeons, and Dr. Sagarwala, who's our chair of interventional pain, were instrumental in establishing this service line. And I think it really underscores the importance of working together at a hospital. I would say our shared commitment to interdisciplinary teamwork is the most important aspect, to me at least, when we're providing care to our patients and ultimately leading to improvement in their lives. So with that, let's talk about the learning objectives for this talk. So I wanted to describe the pathophysiology of knee OA, discuss treatment options as well as some emerging therapies, and then provide a general overview of genicular artery embolization, highlighting relevant anatomy, techniques, risks, complications, and some of the research that has been done and future clinical trials that are underway. So as an introduction, knee osteoarthritis is a common progressive multifactorial degenerative joint disease resulting from the breakdown of cartilage. It's a major cause of pain and disability throughout the world. Knee and hip osteoarthritis is the 11th highest contributor to global disability, with patients over the age of 55, 10% of patients over the age of 55 having disabling symptoms. Does anyone know what's number 1 on that list? Especially one of the residents? Any guesses? I can't hear you. Mental health. Age? Someone said age. Oh. Risk factors said are age over the age of 60, obesity, joint injury, repetitive stress, genetics, and female gender. These two graphs show the epidemiology of knee osteoarthritis. So on the left side, we have prevalence of knee OA with age on the x-axis, and then we have U.S. incidence of symptomatic knee OA again with age distribution. And what we see is that symptomatic OA develops primarily between the ages of 60 and 79 years old, and men develop symptoms at a younger age. But by the age of 60, the rate of incidence is 70% higher in women compared to men. Historically, knee osteoarthritis is described as a wear and tear process. And it's historically characterized as a non-inflammatory arthritis, as opposed to rheumatoid arthritis, gout, pseudo-gout, which are traditionally classified as inflammatory arthritis. However, the latest research on this topic shows that there's a complex interplay between biochemical changes that occur in the cartilage and synovium, as well as calcification of the joint tissues resulting in osteophytosis, and both acute and chronic inflammatory cycles characterized by angiogenesis. So this picture right here is a representation of the knee joint. So you have the synovium, the synovial fluid, the cartilage, and the bone. And one of the things that you'll see here is that there's this fact, these are all inflammatory factors and biochemical markers. And one of the factors that I want to highlight is VEGF, which is vascular endothelial growth factor, which you can see being produced in the synovium, in the synovial fluid, it's in the cartilage, contributing to these complex interactions, as well as in the bone, contributing again to this complex interaction. VEGF is key to angiogenesis, and it's an increased blood flow in any inflammatory process, especially chronic diseases such as knee osteoarthritis. So this new research on the pathophysiology of knee osteoarthritis comes primarily from the development of animal models. With intentional breakdown of cartilage in these animals, we see that there's a release of inflammatory markers, including cytokines, chemokines, growth factors, matrix metalloproteinases, MMPs, and we see for the first time that there's histologic and angiographic confirmation of abnormal neovascularity, angiogenesis, and neoinnervation, which is most likely the cause of the chronic pain. This is a 2019 study where evaluating biomarkers in humans with knee osteoarthritis. From 48 knees, from 25 patients, they looked at synovial fluid and plasma. They actually extracted synovial fluid and plasma from these patients and evaluated these patients for 47 different cytokines, chemokines, growth factors, these inflammatory markers. And what they found is that there are 6 synovial fluid biomarkers that correlate directly with synovial inflammation, as well as radiographic and symptom severity. And these 6 markers right here, I wanted to highlight again VEGF, the vascular endothelial growth factor. So this, without going into too much detail, I wanted to show these 2 figures from a research study that shows the complex interactions between these inflammatory markers. And this complex interaction is the reason why it's hard to design drugs that inhibit 1 or 2 of these markers in this inflammatory cascade and actually have good clinical outcomes. So meaning if you were to block, let's say, this and this, there would be a way around in this pathway which would still cause the inflammation, the pain, et cetera, everything that we see in degenerative joint disease. This interaction is also highlighted here. So you have cartilage breakdown as well as angiogenesis, which is causing an increase in macrophages and infiltration of macrophages, which in turn are releasing more inflammatory and biochemical markers, which increase cartilage breakdown and angiogenesis. In this part of the interaction, you have an increase in osteophytosis, and here you have an increase in joint space narrowing. And all of this is contributing to synovitis, which ultimately is what is leading to osteoarthritis symptoms of pain. So what we want to do is try to target this interaction, this part right here, and stop the symptoms. This is a summary of the relationship between inflammation, neurovascular plasticity, neoinnervation, and the symptoms of osteoarthritis. Inflammation, as you can see here, can stimulate angiogenesis, and angiogenesis facilitates inflammation. These two processes contribute to the damage and inflammation within the joint space. Neoangiogenesis is also contributing to neoinnervation, and with neoinnervation and increased inflammatory markers causing sensitization of nerves, you have increased pain. Again, this is a very complex interplay between angiogenesis, neoinnervation, inflammation causing damage to the joint and increased pain. Well-established treatment options vary from least invasive, no treatment, self-administering, such as heat pads, ice packs, etc., to knee arthroplasty, which is the most invasive option. NSAIDs are the primary drugs that have been used for decades to treat knee osteoarthritis, and unfortunately, there hasn't been any significant advancement in medical treatment, in drugs to treat knee osteoarthritis. And it goes back to that complex interplay between so many factors in the inflammatory cascade. Physical therapy, weight loss play a very important role in reducing knee pain and osteoarthritis, progression of osteoarthritis. Corticosteroid injections, hyaluronic acid injections are excellent. They provide great short-term results on the order of weeks to 3 to 6 months, but they're short-lived, right? So there's a high recurrence of those symptoms, and those patients typically require reintervention. Knee arthroplasty is still the gold standard for symptomatic severe osteoarthritis treatment for the knee. It has very high efficacy. However, the caveat is that many patients may not be candidates due to age or comorbidities. It's still a major surgery, so there's increased risk of surgical complications, a longer recovery period. And these are the reasons that some patients may not be able to get this surgical procedure done. These are some emerging therapies in the treatment of knee osteoarthritis, including stem cells, PRP injections, laser therapy, acupuncture. And this is from the American Academy of Orthopedic Surgeons. The American Academy of Orthopedic Surgeons gives a recommendation out of 4 stars on these various treatment options. And you can see that none of these therapies make it past 2 out of 4 stars. 2 being basically limited evidence or limited recommendation for using these therapies for the treatment of knee OA. Genicular artery embolization is a minimally invasive intra-arterial endovascular procedure which is performed on an outpatient basis. And it basically consists of selectively stopping blood flow in the abnormal genicular branches. Originally, when this procedure has actually been around for a very long time, for over 20 years. But the original application was for the treatment of refractory intra-articular hemorrhage, also known as hemarthrosis, which can occur post TKA, post knee arthroplasty. It can occur in the setting of trauma, coagulopathy, etc. And basically, endovascular specialists like interventional radiologists would go in, they would embolize and stop the blood flow and stop the bleeding within the joint. However, over the last 5 to 6 years, it has knee embolization, genicular artery embolization, has been applied to treat knee osteoarthritis. And patient selection for this procedure is very important. So there are the three big categories for why patients end up getting this procedure is one, patients who are too young to have a knee arthroplasty, and they use it as bridge therapy. So if you have an arthroplasty done of your knee, good results from that procedure last from about 10 to 15 years. And then after that, you may need revision of that arthroplasty. So these young patients are essentially buying time. They're trying to buy an extra 3 to 5 years so that they can hold off on having that surgical procedure done and hopefully not require multiple repeat revisions. It's also good for patients who are at high risk for surgical complications due to comorbidities, for example, or patients who are avoiding invasive surgery for personal reasons, such as, they can't afford to have the long downtime after a knee arthroplasty. So hemarthrosis results from bleeding within the knee joint from genicular arteries, and this triggers the inflammatory cascade, causing synovitis, neovascularity, neoinnervation, and progressive degenerative joint disease. GAE, when it's being used for treating hemarthrosis, is targeting these two points in the pathway where where you're stopping the bleeding by directly stopping the blood flow from the genicular arteries, but you're also stopping the blood flow in the abnormal neovascularity, the new blood vessels that have developed due to this inflammatory cascade. Stopping, at both of these points will result in decreased joint degradation. This is something that I discuss with all my patients. I, of course, simplify this a little bit, but this is what I call the cycle of inflammation and pain with knee osteoarthritis. And patients get stuck in this cycle, and this causes progressive worsening of their pain, their symptoms, and eventually it becomes quite debilitating. So you have, again, the wear and tear breakdown with the cartilage, which triggers the inflammatory cascade, triggering neoangiogenesis, neovascularity. With the neovascularity, these new abnormal blood vessels, there's an increased influx of biomarkers, biochemical markers, which are, like we talked about, causing synovitis and neoinnervation, which is leading to the chronic pain. And this synovitis, all these biochemical markers associated with synovitis, are causing increased cartilage damage, and you get stuck in this cycle. So the goal of genicular artery embolization is essentially to break this cycle. And again, it's at this point where we're trying to get rid of the neovascularity, the neoangiogenesis, these abnormal blood vessels that are causing an influx of the inflammatory markers into the joint space. So just briefly, this is a general overview of the genicular arterial anatomy. And on the right side over here, we have what are called digital subtraction angiograms, DSA images, where we subtract out all the bone, and the only thing that we see are the arteries. This is the DSA image. This is what we call a native image, where you're seeing the bone and you're seeing the blood vessels. So these are the main branches that we typically target when we're performing a GAE procedure. The descending genicular artery, which usually comes off the distal superficial femoral or the popliteal artery. It has two different branches, a superficial branch which goes to the muscles, the skin, and a deep branch which goes towards the joint space. And this is the deep branch is what we're interested in. On the medial side, you have the superior medial and the inferior medial genicular arteries. On the lateral side, you have the superior lateral and naturally the inferior lateral. You have a lot of patients have a middle genicular. And then some patients also have recurrent ascending tibial artery, which comes off the anterior tibial artery and goes towards the lateral aspect of the joint. And I describe this very briefly because there's so much variation in this anatomy that you have to be a vascular expert to really be able to recognize the variance while you're doing the procedure. I mean, this anatomy is seen in about 10% of patients. You know, the other 90% are variants, which we figure out as we're doing the procedure. Just briefly, I wanted to go over the genicular artery embolization technique. This is the way that I do it. There are other operators who obviously do it a different way. But I like to do ipsilateral antegrade common femoral or superficial femoral artery access. So that means that if I'm targeting the right knee, I'm accessing the right common femoral or superficial femoral artery with the needle angled caudally towards my foot and then going straight down. I also do not use a sheath. So when you put in a 5 French or a 6 French sheath, you have a larger arteriotomy site, a larger point of access, and that obviously increases the risk of complications. It also increases your recovery time after the procedure, which can be up to 2 to 3 hours. By avoiding the sheath and directly putting in a 4 French angle glide catheter or any type of base catheter, I avoid all that. So at the end of the procedure, you literally have a tiny, a millimeter size hole that you get a Band-Aid on. You hold a few minutes of pressure just to make sure there's no bleeding. And about an hour after the procedure, probably even earlier if you'd like, you can have the patient walk around and they're basically back to their normal self. And about an hour after the procedure, they can leave back to their home. Through this base catheter, I put in a microcatheter and microwire system, usually a 2.4 French microcatheter with an 014 or 016 microwire to select out the genicular branches. And then I use a permanent embolic, which most people use now, called, in my case, it's called hydropearls, but that's not the important part. The size is the important part. So I use a 200 micron permanent embolic to stop the blood flow. During the procedure, one of the main goals that we have is we want to avoid non-target embolization. What that means is that when we're embolizing these vessels, there are a lot of branches that are going towards the skin, towards the muscles, and we want to avoid, you know, skin necrosis, muscle necrosis, etc. So one of the things that we do is we put an ice pack. I ask my nurse to place an ice pack on the side that I'm about to embolize, and that causes vasoconstriction of those more superficial branches, and therefore my embolic is more likely to go into the joint space. Another thing that I really like to do is before I start the procedure, I actually ask the patient to point to where their pain is most severe, and I put a little BB, a little radio-opaque marker, so that I make sure that when I'm embolizing those blood vessels, I specifically target ones that are going towards that radio-opaque marker at the site of the most severe pain. So again, with the just briefly an overview of the procedure, this is a digital subtraction angiogram. Again, we've subtracted out the bone, and this is the popliteal artery, which is becoming the tibial vessels down here, and you can see all these genicular branches. Over here, you see the descending genicular artery, and you see the deep and superficial branches of the DGA with these little wispy vessels going towards the skin. And this is what you're looking for. This is this blush. So I've selected out the DGA, the descending genicular, and then I've selected out the deep branch of the descending genicular. And this hyperemia, this is the neovascularity. This is abnormal. This is if I took a 17-year-old and I did this exact same image, you would not see this blush because they don't have any osteoarthritis, right? So this is what I'm targeting for embolization. This is what I want to get rid of by the end of the procedure while preserving the normal blood flow. And this is the end result after embolization. So here you can actually see, this is all from the same patient that I performed at Insight Hospital. This is a radio-opaque BB where the pain was most severe. This also correlated with where his hyperemia was. And then I injected those 200 micron beads to stop and prune the neovascularity, which results in resolution of the pathologic hyperemia, while still preserving normal blood flow to the joint space. These are the risk factors and complications associated with the procedure. They're fairly minimal. We try our best, again, to avoid non-target embolization, especially towards the skin. But it can happen in about 10 to 65% of patients. However, 99% of those patients, it's completely transient. It resolves within 24 hours, well within 24 hours, and patients do not experience any type of pain, discomfort. It's there, and then it's gone. Transient sensory changes, again, very, very rare, almost never occur. Osteonecrosis, less than 1%. This is actually, access site complications are the major risk factor of this procedure. And I minimize that by using a bareback technique where I'm not using a sheath. I'm just using a little 4 French catheter, getting in, taking everything out, holding pressure for 5 minutes, and I'm done. Post-embolization syndrome, which is, again, very rare. Basically, patients have flu-like symptoms after an embolization procedure. This can happen anywhere in the body where you're doing an embolization. People don't really understand why it happens, but once in a while it happens, and it resolves on its own. There is a theoretical risk of delayed recovery after TKA, after knee arthroplasty. A lot of patients that undergo genicular embolization may undergo a TKA in the future. Like if there's a young patient, 5, 6 years later, 10 years later, they might require a knee arthroplasty. But this theoretical risk has never panned out. There's no significant evidence in the literature showing that if you underwent a TKA after a GAE procedure, that you had any different results. Your recovery was the same, your success rate was the same, and it's been performed successfully without any complications in patients with prior GAE. This is an example of the transient skin changes. You see a little kind of bluish redness of the skin, and this is actually 3 different patients. It can be a little bit more severe, less severe, somewhere in the middle, but it resolves on its own. And this happens not infrequently, like I said, about 10 to 65% in the literature, but 99% of these patients, it's completely transient and totally clinically insignificant, at least. This is a patient that from a patient that I performed a GAE on at Insight Hospital. It was a 65-year-old patient that was referred to me by Dr. Bookatz because the patient had comorbidities which prevented the patient from getting a knee arthroplasty. So I've selected out the descending genicular again to just really highlight the hyperemia and the pruning after embolization. The pre-embolization and the post-embolization, the superior lateral. And again, this is, you can see right here, so maybe it's a little bit more difficult to see, but this is, you can see a radial peak BB right here, which is where the most severe pain was. And you see right here is where all the hyperemia is as well. And again, the pruning of the vessel after embolization, and the same thing in the inferior lateral. So I want to talk a little bit about research studies on genicular artery embolization. But before we get into research studies, we have to talk a little bit about the classification systems and the language that's used when people do research in this topic. So the first thing is the knee osteoarthritis grading system, which is called the Kellgren-Lawrence system, KL grading scale. And this grades knee arthritis severity based on radiographs, ranging from normal all the way to severe, grade 1 to grade 4. And essentially there's increased osteophytosis, increased joint space narrowing, and then in the most severe cases, there's also subchondral sclerosis, this kind of whitening that occurs over time with joint space narrowing. Quality of life grading systems are very important, right? So this is as a clinician, this is what matters at the end. I don't really care about radiographs. I don't care about angiograms. What I really care about is, are patients getting the symptomatic relief, and is their lifestyle being restored after having these procedures done, or whatever is the treatment of choice. Multiple quality of life grading systems exist. The primary one being knee injury and osteoarthritis outcome score, which is KOOS. The Western Ontario and McMaster University's Osteoarthritis Index, also known as WOMAC, and the Visual Analog Scale, VAS. So KOS consists of 42 questions assessing pain with various activities, other symptoms such as stiffness and instability, as well as activities of daily living, sports and recreation activities, and general well-being and mental state. WOMAC consists of 24 questions which assess pain, stiffness, physical function, and both of these, the KOS and the WOMAC, are really good because they're comprehensive, right? They really kind of capture what is going on in your life and what is really debilitating. Why are you here to see me? And it's not just about pain. It's like, your mental health, your instability, etc. Visual analog scale, much more basic. Basically, you ask a patient, hey, point to where you are on this scale, and that's it. That's the only question. I wanted to spare you guys going through all of these research studies, so I created this this chart which summarizes pretty much all of the most of the important studies that have been done over the past couple of years, starting with 2017, when Akuno in Japan reported the first GAE trial with 95 patients. It's a single-arm study. He used a imipenem, which is a temporary embolic, and it's a long study. It lasted for about 2 years. So the first column shows the study, the year that it was done, 2017 all the way to 2023. The type of study, most of these you'll notice are single arm studies, which is not great. We want randomized control trials for this to really take off. And there's only 2 RCTs in the entire literature. The number of patients also varies from 16 all the way up to 95. The age is primarily in the 60s, which is what we expect for knee osteoarthritis. The KL severity, which is the radiographic severity of knee osteoarthritis, also varies a little bit. The amount of arteries targeted, so you remember when I did the procedure, I targeted 4 arteries. The average is somewhere between 1 to 3. Embolic agent also varies, so Embozine, Embospheres, these are permanent embolics, as opposed to imipenem, which is a temporary embolic. The follow-up period is very variable. There's 1 month all the way up to 2 years. And then in the last column, you have success rate. And in parentheses, I noted what was the author's definition of success. So for example, here, 50% decrease in the WOMAC score is considered a success. Here, they're much more liberal, 16% decrease in the WOMAC score, and so on. So the success rate is relatively high, right? So it ranges from 43% all the way to 86%. Most of them are in the 60s to 70s, low 80s. But this, this line really bothers a lot of people, right? So this is a randomized control study. It has only 59 patients, but it's a negative study. It only showed 43% improvement in the KOS, and this was meaning the controls did better. This is a 2023 systematic review meta-analysis that was published from the NYU group, which looked at 9 recent studies, 270 total patients with 339 knees, and a follow-up period of 1 to 48 months, the average being about 12 months. And they did simulations based on these patients. So MCID is minimal clinically important change. Give me 1 second, sorry. Difference. Minimal clinically important difference, MCID. So this is the threshold where a patient is feeling a change in their symptom. It's just a threshold. It's not like where you're trying to get. It's just the minimal, the least amount of change that you need for a patient to actually feel that something happened, that something got better. SCB is significant clinical benefit. This is the threshold for clinical success. This is where this acts as basically in studies as defining the clinical success that we're trying to achieve. So in these 9 studies, 78% of patients achieved visual analog score, VAS, minimal clinical benefit at 12 months. 92% achieved WOMAC minimal clinical benefit at 12 months, and 78% actually had significant clinical benefit based on WOMAC at 12 months. So it's very promising. And here, again, you can see this is the VAS and this is the WOMAC scales, and you can see, and on the x-axis you have 1 month, 3 months, 6 months, 12 months. And one thing to note here is that the most significant decrease in pain level happens within the first month. So that's great, right? So you're getting very good benefit right within the first 30 days after the procedure. And then it kind of levels off, the significant decline, and then kind of, doesn't get much better after that. So this, to me, is very important. FDA will not grant approval based on single-arm studies. So right now, all the work that we do with genicular artery embolization is considered off-label, which is not uncommon. There's a lot of things that we do off-label in medicine all the time. And when we do clinical studies, we get a device exemption from the FDA to perform a clinical trial. But to get true FDA approval for embolics to be used in genicular artery embolization, like it is in, hemarthrosis or uterine fibroids, for example, you need randomized clinical trials. RCTs are also required for society guidelines. If you want to be incorporated into the Orthopedic Surgery Society guideline, you need these RCTs. Thus far, like I said, the RCTs are either negative or short-term follow-up, and there's only 2 of them, which we discussed. And of course, universal acceptance from insurance companies. We perform these procedures, and some insurance companies will give approval, and some insurance companies will say that it's experimental and it's not approved. These are 3 different randomized clinical trials that are happening right now. The Gaucho study is comparing imipenem and cilistatin. Imipenem, which is basically an absorbable embolic, to microspheres, which are permanent embolics. So this is to resolve the problem of are absorbable embolics better or permanent embolics? Genesis 2 is a large study. It's 110 patient enrollment over a 3.5-year follow-up. And the preliminary results are going to be released hopefully later this year. This is from England. And then the Gravity trial, which is being performed in the US at UCLA, has 100 patients comparing GAE versus observation. This style, to me, I think Genesis 2 is very, very exciting because it's RCT with a sham procedure as well. So the control arm is a sham arm, which as opposed to observation. So circling back to where we started, so treating knee osteoarthritis requires a multidisciplinary approach with IR, orthopedic surgery, interventional pain, rheumatology, PT, OT, etc. And with a team approach, obviously, we're able to select the right treatment for the right patient and optimize success while minimizing complications. I would like, let me see who's in the audience right now. I don't have do I have any Michigan people in the audience right now? Oh, yeah, Yasser is here. Okay. So, and I'm sure there's some Michigan people listening online or will listen to this presentation hopefully in the future. And I'll draw their ire a little bit by saying that I think the 96-97 Chicago Bulls team with these 3 individuals, Jordan, Pippen, and Rodman, were the best basketball team ever assembled. But it's really important to realize that if you want to win 72 games in a championship, you have to work together. You can't do it on your own. Jordan in '88, he won the MVP, the Defensive Player of the Year, the highest scoring average, and still lost. Right? Can't do it by yourself. So even though my Michigan colleagues will say, the Detroit Pistons are great, and they're probably not going to agree with me that this is the best team ever assembled, I think they will agree that this is the best team assembled. With our orthopedic surgeons and our interventional pain doctor, Dr. Sagarwala, Dr. Bookets, and Dr. Wahood. I'm just honored that I can work with such an incredible team here. I'm more like Tony Kukoc when it comes to treating knee osteoarthritis. I'm just a spark off the bench, but these guys are the starters. These are my references, and thank you so much. So I was asked if there are any questions. We can have a little Q&A. I'm happy to answer any questions. If not,
can you go back to the
sure.
the big chart slide with all the different studies? Yeah, that's fine. So I have a lot of questions from this slide. So in terms of like patient selection, are the results in any of these stratified in terms of were patients that had more severe scores, either clinically or radiographically, more likely to succeed?
You know, I'll be honest with you, I don't remember. I can't tell you individually from each study how they were stratified, but I can tell you that this is the overall success rate. And of course, the natural assumption is that the patients with the more severe disease, actually, it's hard to tell. Maybe the patients with the more severe disease had greater or less clinical benefit. It's hard to tell. I would have to go back and exactly look at how they stratified for each study. It's a good question. I'd have to do another deep dive into each study.
Yeah, because I guess my overall question is like patient selection.
Yeah,
I mean, I get it that patients who aren't surgical candidates, they're obvious choices for this.
right.
But for patients who are in the right age range, who have severe disease, you know, should there be kind of a staged approach where we should at least try this before surgery? Or I guess I wonder how you guys are working in that interdisciplinary mode to select patients for this, or to take patients straight to, yeah.
So right now, the way that the guidelines suggest and the way that they stand is that most patients, if they're able to get a knee arthroplasty, they usually go for that. That's still considered the gold standard. I know Dr. Sagarwala offers some excellent minimally invasive options as well, such as RF ablation of the nerve, right? So that is targeting, while I'm targeting neoinnervation, while I'm targeting neovascularity, he's targeting neoinnervation. So that's also an excellent approach. And there aren't any good studies to suggest, to say, which patients should go towards the ablation side, which patients should go to the embolization. What we do know is that the best results for the vast majority of patients is going to be with the arthroplasty. The patients that typically, again, end up coming to me that I've seen are patients who cannot get the surgery done. Or, you know, Dr. Sagarwala thinks that they have not had a good result with the RF ablation, or they might not be a good candidate for the RF ablation for one reason or another. So those patients end up coming to me. I personally have not seen the category of like the patients who are too young to have an embolization procedure done, and it would be, to have a arthroplasty done. I'm not, those patients may be opting to just get the steroid injections or some of the other therapies like PRP, for example. But it's an excellent question, Scott. I think it's that a lot of the research that is required to answer that question has not been done.
I might have missed this part, but the material that you use to embolize, is it similar to what you use to embolize, for example, in mesenteric artery or intercostal artery, or is it different?
It's so for this procedure, I use embospheres or these small beads, embolic beads, I guess you can say. They're made out of this special material that is made to be put into the body. You can't have an allergic reaction to it. The question that you're asking is it the same material that is used to embolize mesenterics or other types of embolization procedures? It varies. So for example, when it comes to mesenterics, sometimes we opt to coil. Sometimes we opt to use embolics. The benefit of embolics versus coiling, I'll tell you, is that coiling typically has to be done in a more proximal vessel. So if I try to, and these are really, really tiny vessels, right? Like for example, some of the mesenteric vessels are very tiny. So if we tried to coil this vessel off, it would cause too much ischemia and you would get osteonecrosis and a poor result. So embolic material, these small particles, especially the ones that I select are 200 microns, they actually go into those really tiny abnormal hyperemia type vessels, the ones that have formed due to the neovascularity and they cause that blush while preserving the larger blood vessels. It's kind of, this selection of embolic and also embolic size is very important, and it goes into something that is a little bit beyond my scope of understanding with flow dynamics and the physics behind it. But basically, the general idea here is that if you embolize with something too big, you're going to cut off the bigger blood vessels, which are important. And selecting these really small 200 micron blood vessels really just goes into these small blood vessels, which are the abnormal ones. When it comes to mesenterics, it kind of varies, right? Like what is if a larger vessel is bleeding, you might coil off. If a very small distal vessel is bleeding, you might want to use an embolic. But the risk of using an embolic is that you can cause mesenteric ischemia, which could be a huge issue. So it varies from situation to situation.
Would it be similar to doing an intercostal artery embolization?
Sometimes. Again, it depends on the size of the blood vessel that you're targeting and the amount of bleeding that you're getting. When it comes to intercostal embolization, one of the most important things is that you don't want to jail off the blood vessel, right? So what you do is, let's say you go in as deep as you can, you embolize with these beads so that you stop the blood flow, and it's a permanent embolic, and you get out. As you know, in your specialty, these intercostal vessels can rebleed, or even the bronchial arteries, for example, can rebleed after embolization. So if you put in a large coil proximally, you're going to jail yourself off, and you'll never be able to get around the coils to get back to the bleed. So when we're worried about jailing off a small blood vessel, that's when we tend to use this in those types of procedures.
Would patients after embolization see any benefit from the injections again, or they didn't want to do surgery, would they just come back and get it?
No, so that's a great question. So this procedure doesn't obviously preclude you from getting any future treatments like knee injections, knee arthroplasty. And it's hard to say if the data hasn't gone out long enough. There has not been enough patients, I guess you can say, which have required repeat genicular artery embolization. So I don't know the answer to your question whether a repeat procedure would be beneficial. What we have seen is that patients who have gone on to get knee arthroplasties do really well. It's actually a very interesting question, because I've been talking with some of the specialists here about possibly doing studies where we do combination therapy. Maybe we do the RF ablation with the genicular artery embolization, or maybe in a staged fashion, and see if we get better results. So it's a great question. We just don't know the answer, in short. Anything else? Thank you, guys. I really appreciate it.
Thank you. Dr. Saeed had to leave, so I'm just going to close this out. Thank you, guys. Thank you, Dr. Ahmed, for your presentation, and thank you to all of you for coming. If you guys didn't sign in on the sign-in sheet, could you please do that for me? Thank you.